heart muscle depends exclusively on oxidative phosphorylation for energy needs. Oxidative phosphorylation means that only with the utilization of the oxygen, ATP is produced within the mitochondria. So there should be a continuous supply of oxygen for the functioning of the heart. In fact, there should be a balance between the oxygen supply and oxygen demand. If there is an imbalance, then it leads to ischemic heart disease. And ischemic heart disease manifests as either angina pectoris, in which there is pain with exertion but it is relieved on rest. So it is a sign of ischemia of the heart. Ischemia occurs, that is decreased blood supply occurs with exertion, but it is relieved at rest, because at rest that much oxygen supply is sufficient for the heart. Myocardial infarction is the death of the myocardial tissue which can occur when there is ischemia. So that much oxygen supply is not sufficient for the heart, resulting in the death or the necrosis of the heart muscle. Then there is sudden cardiac death, in which if a huge amount of the heart is involved with myocardial infarction, then it can lead to sudden cardiac death. And also most of the times the cause is arrhythmia, because there is death of the tissue and it leads to arrhythmia. There is disturbances in the conduction of the nerve impulse within the heart, so it leads to arrhythmia. Then finally there can be chronic ischemic heart disease with congestive heart failure. In this, because of small infarcts which have happened in the heart over time, it leads to congestive heart failure over time. So it occurs due to accumulation of small ischemic insults within the heart. The first three, they are known as acute coronary syndrome. So suddenly they manifest. And the causes of these manifestations can be decrease in oxygen supply, as I told you before. And the most common cause of decrease in oxygen supply is the blockage of the coronary arteries by atherosclerosis. So there is an ongoing process of atherosclerosis which may occur over a period of years. And then because of some insult to this atherosclerotic plaque, maybe some hemodynamic disturbances occurring, and this plaque, if it is vulnerable, it will rupture. This rupture in turn will lead to initiation of thrombus formation. Okay, and when this thrombus is formed, then it is a sudden occlusion of the artery which ultimately leads to myocardial infarction. Then there are other causes which can lead to increased oxygen demand. Suppose there is severe fixed coronary atherosclerosis. It has not ruptured, but there is severe fixed coronary atherosclerosis. Now if there is increased oxygen demand, as in case of hypertension or in case of tachycardia, person is exercising, there will be increase in heart rate, and then there will be increase in the oxygen demand, or even emotional stress. If it is too much, that also leads to increase in autonomic activity, leading to tachycardia and thus increasing the oxygen demand. In that case also, because there is fixed atherosclerosis, it will not be able to supply the increased oxygen which is in demand by the heart. So in these cases, mostly it leads to subendocardial infarction. Okay, subendocardial infarction. Mostly if there is increase in oxygen demand and there is severe fixed atherosclerosis, generally it leads to subendocardial infarction. However, sudden occlusion of the coronary arteries because of the atherosclerotic rupture and thrombus formation, it leads to transmural infarction. That means the whole layers of the myocardial wall is involved. We will see later what is the difference between this transmural and subendocardial infarction. Here I am trying to explain that what can lead to myocardial infarction. Then there might be some other causes which can lead to small infarcts within the heart muscle, and this can occur due to vasospasm, inflammation of the vessel. There can be vasculitis, or there can be small emboli from the vegetations. Maybe in the valve vegetations have occurred, and from there small emboli break off and block the coronary vessels. Okay, so there can be emboli, right? These all can lead to microinfarcts. Now apart from this, there can be other causes in which the blood vessels are normal but oxygen supply per se is decreasing. Like if there is decrease in oxygen itself, decrease in oxygen in blood, say suppose in case of pulmonary edema. In pulmonary edema, oxygen will diffuse less, so there is less partial pressure of oxygen in the blood. Hence, if increased oxygen demand occurs in the heart, that much oxygen cannot be delivered. Okay, so in case of pulmonary edema, there will be decreased oxygen in the blood, which can lead to MI. Then if there is decreased blood volume, as in case of hemorrhagic shock, okay, or if there is decrease in oxygen carrying capacity, in case of anemia, hemoglobin is less, so oxygen cannot be carried that much in the blood. Okay, so they all can also lead to myocardial infarction. However, most common cause for myocardial infarction is atherosclerosis with rupture. That is the most common cause. So what is myocardial infarction? We have seen myocardial infarction is death of myocytes due to decrease in oxygen supply to the muscle. Okay, this oxygen supply, either it can be actually absolute decrease or it is not enough to fulfill the needs of the heart muscle. And most common cause is atherosclerosis with rupture, I told you. So here this is the diagram of the vessel and this is the lumen of the vessel. Okay, here it is showing post-mortem, autopsy has been done, right? So in this case, this fatty tissue of the atherosclerosis is not seen because it is just washed away, and here it is showing the region of the rupture. In this case, we don't see a thrombus formation in the figure, but here you see that the thrombus has formed because of the plaque rupture. Rupture has occurred at this place and thrombus has formed, leading to complete occlusion of the vessel. So what is the mechanism of this thrombus formation? So there is already presence of atherosclerotic plaque, and if it is a vulnerable plaque generally is a plaque in which there are more inflammatory cells, or there is less smooth muscle cells. Smooth muscle cells in the plaque are important for the synthesis of the collagen, the fibrinous cap. If there is less number of smooth muscle cells, then there will be less synthesis of the fibrinous cap, so it will be more prone to rupture. Increased inflammatory cells, they secrete the matrix metalloproteinases, so they break down that fibrinous cap. Okay, so if the cells are more, then also the plaque is vulnerable. So if there is some inciting factor for such plaque, inciting factor can be, there will be hemodynamic disturbances, maybe because of hypertension, maybe because of heavy exercise, which leads to increased flow. Increased flow will cause the rupture of the fibrinous cap. Or there is intense emotional stress. Intense emotional stress means there will be autonomic nervous system activation. That also can lead to this hemodynamic disturbances. So there will be rupture of the plaque. Okay, and this rupture of the plaque, the plaque has here the fibrinous cap, again and again I am telling. So this is ruptured and this leads to exposure of the subendothelial collagen and the lipid material which is present within the plaque. So exposure of subendothelial collagen. This in turn leads to platelet adhesion. Okay, this is the mechanism. Whenever thrombus formation is occurring, this is the mechanism. Exposure of subendothelial collagen, platelet adhesion, activation, aggregation. Okay, so there will be activators of the platelets which are released, that is the ADP, thromboxane, A2. They are leading to platelet activation and aggregation. So this is the thrombus which is formed, right? Also there is release of the tissue factor and this leads to clot formation, right? So this is the mechanism of thrombus formation. This ultimately leads to acute blockage of the vessel and hence leads to myocardial infarction. Now, how much of the heart muscle will be involved in the myocardial infarction depends upon the site of the involved vessel, which vessel is involved and where it is involved, and presence of collateral circulation, whether collateral circulation is present or not. So this will determine that how much of heart muscle will be involved, whether it will be of full thickness or only involve some portion of the wall. So these two factors are very important, and later on the changes also which are occurring in the infarct also depend on these, plus the duration of the infarct. How much time has passed will determine that how much of the heart muscle now will die. If the duration of the infarct is lesser and the intervention has been done faster, then maybe the amount of the heart muscle which is involved will be lesser. So here there is a diagram showing the supply of the blood flow to the heart. We have two main arteries which arise from the aorta, that is the left coronary artery and the right coronary artery. It is important that we understand that which part of the heart these arteries are supplying. Left coronary artery has two main branches, that is the left anterior descending branch, left anterior descending artery, and left circumflex branch. Okay, so let me write here that there is right coronary artery and there is left coronary artery. Left coronary artery, we have the left anterior descending artery and left circumflex artery. Left circumflex artery is supplying this area. Okay, so it is supplying the lateral wall of the heart, lateral wall of the left ventricle. Lateral wall of left ventricle. Left anterior descending artery, you see it is anteriorly, it is coming, so it is supplying anterior wall of left ventricle, anterior wall of left ventricle, plus it is supplying 2/3 of ventricular septum, anterior 2/3 of the ventricular septum, plus it also supplies the apex of the heart, right? Right coronary artery supplies the right ventricle. This side it is supplying, so it is supplying the right ventricle. Now, posterior and the basal part, posterior and inferior aspects of left ventricle we have not discussed. Well, there is another artery, that is the posterior descending branch, and this posterior descending branch can arise either from right coronary artery or it can arise from left circumflex artery. And this posterior descending branch supplies the posterior wall, the inferior part of the left ventricle, posterior wall of the left ventricle, inferior part of the left ventricle, and also the posterior 1/3 of ventricular septum. Okay, here we have seen anterior 2/3 of the ventricular septum is supplied by the left anterior descending branch. This posterior descending branch is supplying the posterior part of the left ventricle, inferior part of the left ventricle, and posterior 1/3 of ventricular septum. Now, 80% of the times this branch is arising from right coronary artery. 20% of the times it arises from left circumflex artery. But because this branch is arising from right coronary artery, by convention, right coronary artery is known as the dominant artery of the heart. Okay, dominant artery. Remember, whichever artery this posterior descending branch is arising, that is known as the dominant artery. Yes, I understand that actually left coronary artery is supplying the major part of the heart, but still by convention, from whichever artery posterior descending branch is arising, that is known as the dominant artery. 80% of the time it is right coronary artery and 20% of the times it is the left circumflex artery. So here I discussed about the blood flow. Now let us go on to discuss that how the heart muscle will be involved. So two things are there, site of involvement of the vessel and the development of the collateral circulation. Remember, if the atherosclerosis has developed over years, there is slow occlusion of the arteries and lot of collateral circulation develops. Basically, this right coronary artery and left coronary artery are end arteries. Okay, so they supply their own area in the heart without any anastomosis, without any cross connections between the vessels. However, there are very small collaterals which are closed. Actually, you see there is here some collaterals are there which are closed collaterals. But when there is slow occlusion occurring within the vessel, so here the atherosclerotic plaque starts, suppose, then in that case these collaterals start opening between the vessels. Okay, so when there is slow occlusion over the years, then there is some collateral circulation which is present, and depending on how much collateral circulation has developed, the amount of the heart muscle which will suffer with myocardial infarction, it will change. If there is a more collateral circulation, then the heart muscle, the area of the heart muscle which will be involved will be lesser. Now next is that what is the site of the involvement. Most commonly this atherosclerosis is present in the epicardial arteries. See, this is the artery which is present on the surface of the heart. Okay, this is present on the surface of the heart. This is known as the epicardial artery. Then this is suppose the wall of the heart muscle. Okay, this is the surface. Then this epicardial artery gives branches known as the intramyocardial branches. So they are going within the surface of the heart, and finally they form the subendocardial vessels, subendocardial arteries. Okay, so epicardial arteries, intramyocardial arteries, subendocardial arteries. Atherosclerosis most commonly affects this epicardial arteries, and if these epicardial arteries are affected, then the area of the heart which will be involved will be maximum, and generally it is the full thickness of the heart muscle which is involved. Full thickness means that you see, this is the thickness of the heart, and here blood is present. Here blood is present. So there are three layers of the heart. See, say suppose this is the endocardium, then we have the subendocardial region. Subendocardial region, basically this is the full layer of the myocardium. This is the full layer of myocardium, and this is the surface of the heart, that is the epicardium. Okay, so when the infarct occurs in this full region, that is known as the transmural infarct or full thickness infarct, and generally it occurs if epicardial vessels are involved. On the other hand, if only this area is involved, okay, generally like 1/3 thickness of the myocardial wall is involved, then it is known as the subendocardial infarct. So remember that this particular area is the first to be involved in infarction, in necrosis. See, even if there is transmural infarct, the area which first undergoes necrosis is always the subendocardial region. Why? See, the blood is flowing from epicardial to intramyocardial to subendocardial region. So, the blood flow reaching there is the last, it is via the small vessels, and because these intramyocardial vessels are within the thickness of the heart, so when the heart contracts, these vessels are compressed. So compressed means there will be decrease in the blood supply to the subendocardial region, isn't it? So that is why this area is more prone, subendocardial region is most prone to necrosis. And when we are talking about the site of involvement, so we have told that whether it can be subendocardial or it can be full thickness, but where in the heart it will involve, that depends on that which branch of the coronary artery will be involved. So we have discussed about the area which is supplied by these various arteries. So tell me, if left circumflex branch is involved, which side will be involved? It will be the lateral wall of the left ventricle, which will be affected by the myocardial infarction. If it is the anterior descending branch, then maximum area of the heart will be involved. Okay, so there will be involvement of the anterior wall of the left ventricle. There will be involvement of the anterior 2/3 part of the ventricular septum and also apex of the heart. Okay, and this is the maximum area of the heart which is involved, and generally if it is not treated in time, it will be fatal. The person is going to die. Then if right coronary artery is involved, then right ventricle can be involved. Then because the posterior descending branch is from the right coronary artery, posterior and inferior aspects of left ventricle and posterior 1/3 of septum can also be involved. And the most common vessel which is involved is this left anterior descending artery. This is involved in 40 to 50% of the cases, while right coronary artery is involved in 30 to 50% of the cases, and left coronary artery is involved only in 15 to 20% of the cases. Okay. Now, moving on to the concept of ST segment elevation MI and non-ST segment elevation MI. If the infarct is transmural, that is, it involves the full thickness of the heart muscle, then generally in ECG leads, we get ST segment elevation. Remember this, okay? ST segment elevation occurs in leads which are overlying the area of the heart in which the infarction has occurred. Remember that, okay? It's not that in all 12 leads we will get the ST segment elevation. So depending on where the infarct is occurring, we will get the ST segment elevation in those particular leads, okay? For example, if the infarction is in the anteroapical region, that is the anterior and in the apex, with the involvement of left anterior descending artery, then we will see ST segment elevation in V3, V4 leads. If inferior wall is involved, like in case of the involvement of posterior branch of the right coronary artery, then we see in the case of lead 2, lead 3 and AVF. Okay, so these are known as the contiguous ECG leads which are overlying that particular area of the heart. Okay, then we have the ST segment elevation MI. This occurs in case of subendocardial infarct, that is the full thickness of the wall is not involved, only subendocardially infarct is occurring. So we see non-ST segment elevation MI. And we have seen the various causes before. Transmural infarct occurs due to the involvement of the epicardial arteries by the atherosclerotic plaque and its rupture. Subendocardial, we saw that it is due to other causes, that is there is a fixed coronary block and suddenly there is increase in demand of the oxygen by the heart. And there can be in fact other causes which can lead to microscopic infarcts. Again, we have seen before, like a small vessel occlusion by vessel spasm, vasculitis, embolization of wall vegetations. Now here it is showing again the areas of the heart involved, but little bit in diagrammatic manner. So if there is involvement of left anterior descending artery, this is the left anterior descending artery, okay, this is showing the various arteries in the heart, the cut section, okay. So if there is blockage of the left anterior descending artery, this much anterior 2/3 of the septum and the anterior wall of the heart is involved. If there is blockage of the left circumflex artery, then it is the lateral wall of the heart which is involved. If there is blockage of the posterior descending artery, then it is the posterior wall and the posterior 1/3 of the septum which is involved. Here it is showing the subendocardial, that is non-ST segment elevation MI. So you see, this one is occurring that there was atherosclerotic plaque which has ruptured, but the treatment was started on time. So first area which is involved, I told you, is the subendocardial region only. So in this case, that the reperfusion was started, the treatment was started. So the area which is affected is only the subendocardial infarct. So it is basically the partial occlusion which has occurred, or we can say transient occlusion which has occurred. Because of that, subendocardial infarct has only occurred despite the thrombus formation. And here it is generalized hypotension. So the arteries were already narrow. Now there is development of the hypotension. So there is decreased blood supply to the heart via all the vessels. So what we see is circumferential throughout the wall. Okay, there is circumferential involvement of this subendocardial infarct. Okay. Then finally we are seeing microscopic infarcts that are forming small infarcts are seen throughout the myocardium, and we have seen the causes also for this. Now what is the response of myocardium? Response of myocardium can be classified into three ways, where we have the functional changes, biochemical changes and the morphological changes. Functional changes, as soon as there is decrease in the blood supply, there will be loss of contractility, and even if the reperfusion is started, the treatment has started, even sometimes after that, the functionality of the myocardium cannot return to normal. So that is known as stunned myocardium, and that is because of certain cellular biochemical changes which have occurred. It takes some time for the heart to recover even after the treatment has been started. Okay, so that is known as stunned myocardium. Then we have certain biochemical changes, that because of the decrease in the oxygen supply, there is decrease in the metabolism, and hence there is decrease in ATP, and there is lactic acid accumulation. Then morphological changes which occur are glycogen depletion, cell and mitochondrial swelling which are seen. And very important to remember that if ischemia is greater than 20 to 40 minutes, then irreversible injury will occur. Okay, so glycogen depletion and cell and mitochondrial swelling, they are reversible changes. Okay, but if ischemia lasts for greater than 20 to 40 minutes, then irreversible injury is going to occur. And what is seen is coagulative necrosis. Coagulative necrosis always first in the subendocardial region. And earliest detectable feature of myocyte necrosis is disruption of integrity of sarcolemmal membrane. Okay, the cell membrane which is there, sarcolemmal membrane, there is breakdown of that, and that can be seen in electron microscopy. So that is the earliest detectable feature of myocyte necrosis. Along with this, let us see pathologically what are the changes which occur in heart after MI. Actually, these changes occur in both the infarcted region, and also in the non-infarcted regions. Okay. So infarcted region, what will happen, that it is dying. Okay, so we will see coagulative necrosis. Coagulative necrosis, this is the concept you should know, that whenever there is death of the tissue, necrosis is seen. In case of heart, we see coagulative necrosis. Then there is infiltration of the inflammatory cells, so we say inflammation. And these inflammatory cells, neutrophils will be there, macrophages will come and they will eat up the dying tissue. And finally, there will be formation of the granulation, there will be deposition of the collagen, so they will be repaired. Okay. So these are sequential changes which occur in the infarcted region, that is the coagulative necrosis, inflammation and repair. While the non-infarcted regions, see, because of the infarct, these non-infarcted regions have to work more. So there are compensatory changes in this non-infarcted region, and these include hypertrophy as well as dilation of the heart. Okay, hypertrophy as well as dilation of the heart, and these are the result of ventricular remodeling which is occurring. They have to work more, right? So there is ventricular remodeling. In short term, these changes are useful, but later on, due to excessive dilation which occurs, there is increase in oxygen demand. Increase in oxygen demand. See, they are working more, but because of dilation, they are not able to build up pressure within the ventricle. So for the same pressure development, they have to work more. Okay, so there is increased oxygen demand, and hence it leads to ischemia to this region as well, and this leads to decrease in the heart function ultimately. Okay, so this can lead to heart failure. So it is very important to intervene in this stage of ventricular remodeling so that it doesn't go over the top and becomes harmful for the heart. Okay, so there are drugs which can be helpful like ACE inhibitors. I will not talk about the treatment part, but still, just here remember that because of the ventricular remodeling, there can be adaptive changes in the heart which in long term will not be beneficial. Now, if we see the pathological changes, what are these? So, I told you that there is necrosis, there is inflammation, and then there is repair. So, here those changes are seen. This is showing the wavy fibers of the heart. Okay. So, here you see this is the normal myocardial, but here the necrosis has started, and because of the collection of the fluid between the cells, we see wavy fibers. And these are seen from approximately half hour to 4 hours after MI, right? If the person dies after like a different time of the myocardial infarction, so we have different people who have died at different time after myocardial infarction, and then we see that what are the microscopic changes which are occurring in the heart. So we can see these wavy fibers which are seen half hour to 4 hours after infarct. Here it is seen neutrophilic infiltration. You see lot of neutrophils are infiltrated, and this is seen approximately 1 to 3 days after myocardial infarction. Then here there is clearing up, right? So what are the cells are dying? They are taken up by the macrophages and they are cleared, and this is seen in approximately 3 to 7 days. Okay, and this days, the number of days which we are seeing, that is generally the time which is taken in healing of any tissue. Okay, in 1 to 3 days there is infiltration of the neutrophils. In 3 to 7 days macrophages do their job, they clear the cells. Okay, then here you see approximately 10 days to 2 weeks we see this granulation zone. Okay, 10 to 14 days, 10 days to 2 weeks, 14 days is 2 weeks. So we see this granulation area. Okay, and here by 2 weeks to 6 weeks there is formation of the collagen, that is the scar formation occurs. Okay, so this blue staining is showing the collagen development of the scar. That takes approximately 2 weeks to 6 weeks, and by 8 weeks it is fully done. Okay, so these are the light microscopic changes which are seen, and grossly also this infarcted area can be identified in autopsy after approximately 2 to 3 hours of myocardial infarction. So if the person has died before, then it is very difficult to identify the infarcted area, but after 2 to 3 hours, it can be easily identified by staining with triphenyl tetrazodium chloride. Okay, this is the stain. It will stain the non-infarcted area. Non-infarcted area will be stained as red. Okay, actually non-infarcted area has the enzyme lactate dehydrogenase. So this TTC, triphenyl tetrazolium chloride, reacts with that and stains the non-infarcted region brick red in color, while the infarcted region doesn't take up the stain and it is pale. It is seen pale. Okay. So that was the morphological changes which occur in the heart after MI. Moving on to the clinical features which occur immediately when the heart undergoes ischemia and there is myocardial infarction. So, we will generally get a history of a precipitating factor, that is presence of vigorous physical exercise, emotional stress, medical or surgical illness. They are going to precipitate the ischemia. So, when there is ischemia, because of decrease in oxygen, there will be pain perception, and that pain generally is substernal. It is a visceral, deep crushing pain which occurs. It can occur below the sternum also, and it may or may not radiate to the left arm, okay, neck region or left jaw. But remember, radiation is not always present. It may or may not radiate, and that occurs because origin of the visceral nerves from the same segment of the spinal cord as that of the spinal nerve. So both the nerves which are supplying the heart and which are supplying this somatic region, okay, this superficial region, they are both arising from the same segment of the spinal cord. So your brain gets confused that from where the pain is coming. Is it coming from the superficial surface or it is coming from deep structure? Deep structure pain, it is not used to, it has never occurred. Okay, so that is why it perceives it as it is coming from the superficial structure, that is from the left arm, neck or left jaw. Okay, so this is known as referred pain. Sometimes there may not be any pain, and that is known as silent myocardial infarction, and that generally occurs in diabetic patients because of the presence of diabetic neuropathy. So the nerves itself are not working, so the person will not be able to perceive the pain. Okay. Then because of the ventricular dysfunction, there will be decrease in the cardiac output, and hence there is increase in the autonomic activity. This increase in autonomic activity causes increased sweating, nausea, and there may or may not be presence of tachycardia. Increase in the heart rate can occur. In fact, presence of pain, substernal deep crushing pain along with diaphoresis, that is along with excessive sweating, is highly suggestive of myocardial infarction. Then again, because of decrease in cardiac output, there can be decrease in blood pressure, there will be hypotension, and there can be loss of consciousness. Again, it is plus or minus. That means it may be present, it may not be present. There can be a sense of profound weakness as well because cardiac output is decreasing. Okay, so there can be presence of profound weakness as well. Then because of decrease in cardiac output, there will be decreased carotid pulse. So if we feel the pulse, the volume will be very less. Extremities will be cool and pallor will be present, again because of decreased blood flow to the extremities. Then because of ventricular dysfunction, if left ventricle is involved, there will be development of the back pressure. So left atrial pressure will increase, there will be increase in the pulmonary vessels pressure. So this will lead to pulmonary edema. So this is developing acutely. Okay. So there will be acute development of pulmonary edema. There will be decrease in oxygen diffusion across the alveolar wall, and this will lead to breathlessness. Oxygen is less in the vessels. Plus, because of the heart failure, there may be presence of S3 and S4 sounds also on auscultation. Then if right ventricle is involved, there will be signs of right ventricular failure, that is there is increase in the jugular venous pulsation, there is presence of hepatomegaly and edema. Now generally we also see that there is some circadian variation, that is MI is most common within few hours after awakening, after waking up. Okay, so it is generally seen between 6 a.m. in the morning to 12 noon. Since increased autonomic activity, we have seen that some precipitating factor, vigorous physical exercise, emotional stress, medical illness, all these are factors which cause increase in the autonomic activity. So this increase in autonomic activity causes some hemodynamic disturbances, the blood flow increases, so that is making the plaque prone to rupture because of this hemodynamic disturbances. Similarly, within few hours after awaking, there is increase in the autonomic activity which is making the plaque rupture. Okay, so that is why there is some circadian variation which is seen, that is MI is seen most commonly between 6 a.m. to 12 noon in the morning, right? Now, if we do ECG, then if it is a transmural infarct, then we will see ST segment elevation with plus or minus Q waves. If it is a subendocardial infarct, then we won't see any ST segment elevation. Important, okay? So, in these cases, we have to go for checking for the serum cardiac biomarkers, and if there is, with these clinical features, if there is elevation of serum cardiac biomarkers, then the diagnosis of non-ST segment elevation MI is confirmed, that is subendocardial infarction is there, okay? See, ST segment elevation MI also, these serum cardio biomarkers rise, but since it is a transmural infarct, and we have to make the decision for treatment very fast, while these lab reports on cardiac biomarkers come very late. So that decision that we have to start the reperfusion therapy, that has to be done very fast, so we don't wait for the results. So even though it has to be given for testing, the decision has to be made well before that. However, for non-ST segment elevation MI, serum cardiac biomarkers are important for diagnosis, okay? So what happens that because of the damage to the myocardium, and I told you that it will be the cell membrane of the cell which will be damaged. So whatever the proteins are present within the cell, they will leak out, okay? So there are contractile proteins within the cell. We have myosin, actin, troponin, tropomyosin, everything is there. So this troponin, which is free in the cytoplasm, will leak into the circulation, okay? So it will enter the lymphatic system, it will be washed away, but so much amount is being released that it will enter into the venous system as well. So there will be increase in this troponin. In fact, there is a whole list of cardiac biomarkers. We have myoglobin, okay? We have the creatine kinase, and especially the creatine kinase MB isomer. Actually, this creatine kinase is a dimer. There is MM isomer, there is MB and BB. We are more bothered about the MB form because this is the one which is specific for the heart, okay? Then we have troponin. We have troponin T and troponin I, okay? So two forms are there, troponin T and troponin I. So if we see that these proteins start rising in the blood after myocardial infarction, and myoglobin is the first one to rise. But for heart, we are more bothered about mainly the troponin. Troponin is the most sensitive and specific marker for myocardial infarction, okay? So this CKMB starts rising between 2 to 4 hours, peaks in 24 to 48 hours, and returns in 4 days, okay? Returns in 4 days. So easy to remember, you see, 2 to 4, make it 24 to 48, and this 4, you make it as 4 days. So just remember this 2 to 4 hours for CKMB. It peaks in 24 to 48 hours and comes back to normal in 4 days. Troponin on the other hand, troponin T and troponin I, again they rise in 2 to 4 hours, peak in 48 hours, 2 days, but they remain in circulation for 7 to 10 days. And remember, this troponin T and troponin I are most sensitive and specific for myocardial infarction. Now, these cardiac biomarkers peak earlier if the reperfusion is started due to washout from the necrotic tissue. So if reperfusion, that means the blood flow is again coming back to the heart, so there will be washout of everything from the dead cells, right? So they are going to enter into the circulation. So it is important, if we are monitoring these cardiac biomarkers, then if these peak earlier, that is a sign of reperfusion. Now, before I move, just one thing I want to talk, that is about the reperfusion injury. So yes, in myocardial infarction, we have to decide that reperfusion has to be started, but sometimes this reperfusion, if is started, then it can cause reperfusion injury also, and that occurs because we have seen that there is mitochondrial damage. mitochondrial damage. Okay, so mitochondria is important for oxidative phosphorylation. Now when reperfusion is started, this oxygen goes into the cardiac muscle, but mitochondria is not functioning properly, so there is generation of free radicals. So we get free radical injury, right? So instead of getting healed, there is progression of this MI. So there is free radical injury. Also there is entry of WBCs and platelets, especially WBCs. They are also going to cause the inflammation. Plus there is calcium overload of the heart, calcium overload. Okay. And in fact, this calcium overload not only affects the normal region, but it also causes changes within the dead tissue itself. So we see something known as contraction bands. So you see here, eosinophilic contraction bands are seen within the myocardium due to this overload of calcium. So even the dead tissue shows certain changes. Okay, with this, let us move on to the final part, that is the complications of myocardial infarction. So first complication is chamber dilation, and that will lead to ventricular dysfunction. Chamber dilation occurs due to weakened muscle. So there is disproportionate stretching and thinning of the muscle. So if there is chamber dilation, there will be ventricular dysfunction. Here this diagram is showing a phenomenon known as systolic stretch. So what is happening, that this is the non-functional muscle, and because of the non-functional muscle, normal muscle undergoes contraction. But when normal muscle is undergoing contraction, there is an outward stretch of the non-functional muscle. So this prevents the development of pressure within the heart. So even if the normal muscle is functioning more, still it is not able to develop the pressure in the heart because of the outward systolic stretch of the non-functional muscle. Then second is cardiogenic shock. Cardiogenic shock occurs especially with the involvement of the left anterior descending artery, because lot of the myocardial muscle is involved and they can be damaged to approximately greater than 40% of the myocardium. So when this much myocardium is involved, then only we get cardiogenic shock. The features are systolic blood pressure falls less than 80 millimeter mercury with increase in the pulmonary capillary wedge pressure greater than 18 millimeter mercury. Okay, only fall in systolic blood pressure should not be taken as a sign of cardiogenic shock. We see both the features. Okay, systolic blood pressure less than 80 millimeter mercury and rise in the pulmonary capillary wedge pressure greater than 18 millimeter mercury. Then there are certain mechanical causes of heart failure, that is if there is wall rupture. Okay, so this wall rupture is seen generally 2 to 4 days after MI. 2 to 4 days after MI. Okay, so because of the rupture and necrosis and then clearing up of the dead tissue, the wall thins out so much that ultimately it will rupture. So this is free wall rupture. Here we are seeing one diagram where there is anterior wall rupture of the heart. Then here it is showing the septal rupture. Ventricular septal defect can occur. So all the blood will go from the left to right side of the heart, and then there can be papillary muscle rupture also. Okay, so here it is showing the rupture of the papillary muscle. Free wall rupture, if there is free wall rupture, then the blood will come out from the chambers of the heart and it will accumulate in the space between the heart muscle, heart wall and the pericardium. So this will cause the development of hemocardium and ultimately it will cause the development of cardiac tamponade, and in fact most of the time it is fatal. Okay, very heroic measures are required to prevent this, but it is generally fatal. Okay. Then ventricular septal defect, it will lead to movement of the blood from the left to right side of the heart. So there is shunting of the blood, mixing of the deoxygenated and oxygenated blood, and we hear a pansystolic murmur in VSG. Okay, papillary muscle rupture will lead to mitral regurgitation. Again, it will also lead to pansystolic murmur. In fact, it is very difficult to differentiate between VSG and MR it develops because of the papillary muscle rupture. Okay, pansystolic murmur is heard on both of these cases. Then next one is development of pericarditis. Pericarditis develops because of underlying myocardial inflammation. So below in the heart there is myocardial inflammation, and because of that extension of the inflammation we get inflammation of the pericardium as well. So there is a release of lot of inflammatory fluid within the pericardium and this leads to fibrohemorrhagic pericarditis. Fibrohemorrhagic pericarditis. This ultimately leads to development of adhesions. Okay, and this ultimately leads to development of constrictive pericarditis. Constrictive pericarditis. Okay, and generally pericarditis develops within 2 to 3 days of myocardial infarction. After 2 to 3 days of myocardial infarction. Then there can be development of mural thrombus, that is within the chambers there can be development of mural thrombus, and this thrombus develops because the heart is not functioning properly, there is no proper contraction, so this is leading to stasis of blood within the heart. Okay, plus there is chamber dilation also, right? This is also causing stasis of the blood, and also there is damage to the endocardium. Okay, so the endocardial damage is also occurring, which is prothrombotic, right? There is exposure of the underlying tissues, so endothelial damage, stasis of blood, dilation, all these promote the development of the thrombus within the chambers, and sometimes this thrombus may break and will lead to development of embolism, blocking the vessels in other places. For example, if there is blockage of the cerebral vessels, it will lead to a stroke. Okay, then development of the ventricular aneurysm can develop. It will again interfere with the proper functioning of the heart, because this part of the heart will not contract normally. There will be development of the systolic stretch. Okay, generally this ventricular aneurysm which develops, it does not rupture. Okay, and why is this aneurysm developing? Again, due to the weakening of the heart muscle, due to the thinning of the heart muscle, we have seen that macrophages clear out the area. Okay, so if proper collagen development has not occurred, proper scar tissue will not form, it will lead to thinning of the muscle, ventricular aneurysm will develop. Then arrhythmia. In fact, arrhythmias can be lethal, and greatest chances of development of arrhythmia are within 1 hour of MI. Within 1 hour of MI, and ventricular fibrillation may develop, which can be lethal. Okay, other arrhythmias can also develop like supraventricular tachycardia, ventricular premature contraction, ventricular tachycardia, bradycardia. Other types of arrhythmias can also develop. And why is arrhythmia developing? It can develop due to electrolyte disturbances, due to metabolic acidosis which has occurred, and also due to slowed conduction in ischemic zones. Okay, so for proper conduction of the nerve impulse, we have the conduction pathway, it is there, and there should never be re-entry of the same impulse. But if within the heart one area is infarcted, then what happens, that other areas get proper impulse, but here there is slow impulse. So the impulse goes around of the infarcted region like this. It takes lot of time, and by the time it reaches to the original site, now it is not refractory, because it has taken lot of time for traveling. Okay, so now it is not refractory, so again the same impulse can stimulate the area, so there is re-entry of the impulse, so arrhythmia can develop. Then congestive heart failure, because if there are microinfarcts, then over time congestive heart failure will develop. Also progressively there may be ventricular dysfunction. We have seen that how there will be ventricular remodeling, how if ventricular aneurysm is there, heart is not going to contract properly, right? So there will be progressive development of congestive heart failure. Then there can be right heart failure as well. Right heart failure as well if right ventricle is involved. Then finally, what are the treatment options? Basically, we have to target the reperfusion. So we have to do the thrombolysis. Thrombolysis will remove the thrombus, but initial atherosclerosis which has occurred, it is going to remain. Okay. Then is angioplasty. Angioplasty with stent placement. Angioplasty with stent placement works on the thrombus which has formed, and also original occlusion which has formed. It interferes that as well, thus increasing the lumen diameter through which the flow is occurring because of the placement of the stent. Another is coronary artery bypass. Coronary artery bypass grafting. So wherever the block has occurred, another conduit is given bypassing that particular block, so that the blood flow can occur through another conduit. So that was about the pathophysiology of myocardial infarction. Thanks for watching the video. If you liked it, do press the like button, do share the video with your friends, and do subscribe to the channel Physiology Open. Thank you.